The other big news within thoracic surgery circles is over the last few years, we've now have the results from two randomized trials, huge randomized trials, comparing segmentectomy versus lobectomy for early stage lung cancer, these small tumors less than 2 centimeters in the periphery of the lung. And it's been demonstrated for the first time that the oncological results, i.e. survival, is equivalent between lobectomy and segmentectomy. And that's big news. Now, if you don't know what I'm talking about, well, traditionally, when we do lung cancer surgery, we remove a lobe of the lung. So you have 2 lobes on the left side, 3 lobes on the right side. And to cure lung cancer, traditionally, we'd have to take an entire lobe out, i.e. half the left lung or a third of your right lung. But it's been possible, actually, to do a smaller resection than a lobar resection, what we call a segmentectomy. So within a lobe, you only take a part of it out. Now, and that preserves more lung for the patient. So after surgery, their lung function doesn't become reduced so much. Now, this operation is difficult to do, but it's been around for decades. The reason we haven't been practicing it is because there's been a lack of clinical evidence saying that it is as good as the gold standard lobectomy. But that's really been turned on its head in the last few years because the JCOG 0802 trial from Japan and the CALGB 140503 trial from North America have now definitively demonstrated that for select patients with these smaller tumors, it's possible to do a segmentectomy and get just as good oncological results. So now it's becoming increasingly difficult for us to say that, oh, you have to do a lobectomy for everybody. For some of these patients, we can do a segmentectomy. Now, this has great implications throughout thoracic surgery because of several reasons, really. Well, first of all, most pressingly for a lot of surgeons, is that segmentectomy is actually a technically more challenging operation. It's something that I think a lot of surgeons need to be retrained in to be able to do proficiently. So it's a challenge there. It's demonstrated that good surgeons can do this surgery quite effectively, but there's a challenge there. Another thing is that if we're going to be doing more of these segmentectomies in future, then suddenly there's a whole new range of patients where we might be considering surgery that we hitherto weren't considering. For example, screening detected small lesions. If you do lung cancer screening with a CT scan, you find a small lesion. Traditionally, you say that, oh, well, you just wait and see because some of these might not be cancer. You don't want to do a lobectomy for everybody. That's too much trauma. But as we move more and more towards segmentectomy, which is much less traumatic in terms of reducing patient lung function, why not lower thresholds for treating a lot of these screening detected lesions, some of which, if not a lot of which, might actually be lung cancer. So you can get in there and treat lung cancer more quickly and with less morbidity by using a segmentectomy, for example. There's another avenue which we need to explore, and that is the increasing detection of what we call multifocal lung cancers. So you might see different cancer deposits in different parts of the lung. And traditionally, if you're doing a lobectomy, if you can't do multiple lobectomies because you're taking way too much lung out. But what if you do multiple segmentectomies for each of these multifocal deposits? It's technically possible to do without doing too much harm for these patients. And emerging evidence over the last several years has shown that if you do good surgery for these multifocal lung cancers, i.e. you're doing segmentectomies, then potentially you're achieving very, very good results. So I think taken in as a whole, I think the rise of segmentectomies over the last few years with the publication of these randomized trial results, this is really revolutionizing a lot of thoracic surgical practice today. Now, this, I think, is the biggest news. There are other advances also, but I probably won't have enough time to talk about that. Instead, I'll answer the other question that you asked. So what are the challenges for surgeons today? And I think the biggest challenge for surgeons is they have to stop thinking within their own specialty, my own specialty, thoracic surgery. Traditionally, surgeons have been quite a closed group. So we talk about making surgical advances in terms of newer technologies, newer surgical techniques, and we congratulate ourselves whenever we do a new surgical procedure. However, it's much more difficult, I think, for surgeons to think outside this narrow box of the narrow confines of surgery. What we need to do today is to think outside that box and work with our partners in respiratory medicine, in medical and clinical oncology, in pathology, in radiology, and all the other specialties. Because what we're seeing is a lot of really powerful advances being made in lung cancer treatment outside surgery. And as surgery today still offers the most effective form of cure, we still need to think of how to implement surgery or integrate surgery with the advances made in other specialties and give a better package for our patients. We can't just sit alone inside our surgical conferences thinking about how to do surgery better per se. We need to think about how to coordinate with our non-surgical colleagues to make things better, combining our treatments. And that, I think, is a big challenge because surgeons aren't really used to that, working outside surgery. We might sit in on MDT every week, but even then, we're not necessarily thinking about how to adapt ourselves. And I think that's where we need to be thinking. Instead of just focusing on, oh, my latest VATS technique, oh, how small can I make my wound? We need to think about, hey, how can I make the survival for this patient better in conjunction, not with just myself, but in conjunction with the oncologist and other specialties? And I think that will take some effort to do. It's not easy to change how a surgeon thinks.